Okay, everybody has been admitted.
All right, I will take it away. Thank you so much, Tracy. Thanks everyone for joining this morning. We'll give it one more minute as people trickle in, and then we'll go ahead and get started.
Casey, I'm here.
Hi, Tammy. Thanks for joining today.
You're welcome. I'm going to mute.
Okay. All right, we'll go ahead and get started. Thanks for joining our training on core competencies for treating people with disabilities for healthcare providers. My name is Casey Pegg. I'm a community organizer with the Pennsylvania Health Access Network. And I'm working on this project as part of the Rural Healthcare Access Project, which is an initiative funded by the Pennsylvania Developmental Disabilities Council to improve healthcare access for people with disabilities in rural PA. I'm organizing this as part of a coalition. The other coalition members who have worked really hard on organizing this are the Perry County Coalition for Better Health and the Nisongar Center for Excellence in Developmental Disability. And also we want to thank the Central PA Center for Independent Living. Today we are going to watch a short video. We will take some questions. Then we will have a presentation from Dr. Susan Haverkamp, who I'll introduce all of that later. But as folks are trickling in, I wonder if you've just joined, if you wouldn't mind just saying your name and where you're calling from, and maybe a little bit about yourself, if you're a person with a disability or if you're a healthcare professional or something of that nature.
I'm Tammy, and I am blind, and I live in Northumberland County.
Thank you, Tammy.
I'm Mary Blackman. I'm a healthcare provider and a PA, and I also have a son with autism. Nice to meet you guys.
Thanks for joining. And Mary is also our featured speaker today, so we'll be hearing more about her.
I'm Max Horwitz. I'm a healthcare provider at University of Pittsburgh. Thank you for doing this.
Thanks for joining. Anybody else before we get started? Okay, so we will go ahead and kick off today's programming. I'm going to show a brief video that Mary and I recorded. Mary, like she said, is a physician's assistant, and she's the mother of two wonderful children, one of which, Elijah, is on the autism spectrum. And today's video is going to be about her experiences taking Elijah to some of his appointments. And then Mary will be available to answer questions and we can discuss. Let me just share my screen real quick. Oh, wait. Sorry, I think I did not do the audio. Let me just try that again.
I could hear it. And I live in Lewisburg. I have, he is now 6, a 6-year-old son who has autism, and he's rated as moderate, so kind of in the middle of the spectrum. And we've had some issues in the past taking him to his regular pediatrician's office where they're not super accommodating. I remember especially when he was younger, he had a lot of problems with fluorescent lights, and a lot of commercial buildings have fluorescent lights, and it's very typical, but they would really upset him. And so the first thing he would do when he would get into an exam room is he would turn out the lights. And then when the provider would come in, she would flip them back on. He would start tantruming, and I would say it's because of the lights. And there would be kind of an argument over whether or not we could work with the lights or not, and it just wasn't very accommodating for his needs at that time. It's not as much of an issue now that he's a little bit older, but when he was younger, with the diagnosis of autism, he had a lot of trouble waiting. And it's super common to wait, 20, sometimes 30 minutes or more in a waiting room when you're going to see your pediatrician. But this would just really set him off. And then if you would count the time from the waiting room and then waiting, again for the provider to come in, it was just almost an hour sometimes wait before he could even be seen by the provider. And by that time he was completely already burnt out. So what I would recommend that we think about now I can speak of autism, but for example, a kid with autism or any client of any age with more severe autism, it's very hard to wait. So just making sure that you have a flag on their chart, so that way you know how to best accommodate, maybe kind of squeezing them in as quick as possible, because I think that would really help the appointment go smoother. And everyone with autism is a little different. Maybe fluorescent lights don't bother some other clients. So just knowing that particular patient and having a note in the chart saying doesn't tolerate fluorescent lights, really difficult time waiting, or needs the spin chair removed from the exam room, because some kids or other clients with autism will use the doctor chair that spins. And I think the key is just really getting to know that particular client and what works and what doesn't work, and just going with it and accommodating the schedule accordingly. I'm thinking of a time where it was about a year after he was diagnosed with autism. So he would have been 5 at this time. He went in for a psychological evaluation appointment, and where we were going, they were very accommodating, meaning that he could step out of the room that we were meeting in and go with a specialist into another room, which was a sensory room, and go let out some energy and play with toys while I was talking with like the psychologist. So little things like that, having sensory items and having the option for them to leave the room is a big deal, and it really is helpful for them to be flexible. My best recommendation for all providers is to realize that autism may be more than what you already know, and it looks different than maybe a certain picture you might have been educated to. And my best advice is, if any parent has concerns with it, just don't delay and refer and get them to a specialist that can diagnose autism as soon as possible. Because in my own story with my son, we had a lot of trouble getting him a diagnosis, and it delayed therapy for a year. And that time frame when they're developing is very critical, and it can really change the trajectory of that patient's life if you can get a diagnosis and get quality therapy at a very young age. So that's my best advice, is if a parent comes in with concerns with autism or sensory concerns, immediately get them to a specialist for diagnosis and then therapy. And if you have local wait lists that are very long, I encourage you to reach out to the local autism community. So that way you have a handle on which facilities are getting people in the quickest. The sooner, the better. Even if patients have to travel to out-of-state facilities to get a diagnosis quicker, that also works. And I know that this is very autism specific, but that is my personal story and my personal affiliation with disabilities and access. One thing that I wanted to mention was that I'm a physician assistant. When I was going through PA school, I was taught certain elements of autism that are true for a lot of clients. For example, lack of eye contact. I was also taught things like lack of empathy, cognitive delays, speech delays, things like that. While that is true for some, it is not true for all. For example, my son, who's moderate, he has extreme empathy, and he does make eye contact. And these things delayed his diagnosis for quite some time because they weren't classic. So I would recommend to healthcare providers who are doing general practice or general pediatrics to really educate themselves on the entire spectrum of autism and what that picture can actually look like. Thank you for letting me say those things. They're really important to me and they mean a lot. I feel like if change could happen, that could just change one person's, one person's story. That would mean a lot.
Okay. So everyone, if you have any reactions or have any questions or comments, please feel free to jump in. I just want to follow up on that, Mary, by asking you a couple of questions. Can you talk more about, so you talked a lot of your experience as a parent, but I was wondering if you could talk a little bit more about your experience as a physician's assistant, any experiences that you've had treating patients with disabilities. I think we may have lost Mary. Mary, are you there? All right. Unfortunately, I think we might have lost Mary, so we'll just wait and see if she rejoins. But for now, we're going to go ahead and move along with the agenda. So next, we have a presentation from Dr. Susan Haverkamp, who is the professor of psychiatry and behavioral health at the Nisanger Center for Excellence in Developmental Disability. And hopefully, if Mary joins back on, we can make some time to do the Q&A with her. But I will hand it over to you, Susan. Please take it away.
Wonderful, thank you. Can you guys hear me? Can anyone say yes? Do you hear me? Yeah, perfect. Thank you. You keep getting a pop-up saying, please join audio.
Hi, Casey. I don't know if you can hear me or not.
Oh, wonderful.
It's Mary Bachman.
Thanks so much for joining back, Mary. We just have a couple of questions for you.
Sure.
Yeah, so
I got kicked off. I apologize.
No problem. So Mary, we just wanted to ask you a couple of questions following the video. So in the video, you talked a lot about your experience as a parent. Can you speak a little bit about your experience as a physician's assistant and any experiences that you've had treating patients with disabilities?
Sure. I used to work in primary care, and I used to see quite a fair amount of people with disabilities. In the town I was in, they had several group homes. And so we would see a lot of adults with disabilities of various types. and usually mental disabilities, but also some physical disabilities. And unfortunately, they would have to wait the same amount of time. They were treated as if it was any other typical person. They would have to wait a long time. The room setup would be the exact same. We would have problem behaviors. We would have all sorts of issues. And like I said in the video, you know, by the time the provider walks in, they could have been waiting an hour. And so then by the time the visit starts, these clients are ready to leave. You know, they don't have any more patience to endure the visit. That's just kind of the takeaway from my experience.
Thank you. And how do you think the healthcare system could better prepare healthcare professionals to deal with situations like that, or generally just improve knowledge and competency for people on the autism spectrum and with other types of disabilities?
Yeah, good question. When I was in school, maybe there was a couple PowerPoint slides on autism that, now that I have a kid with autism, don't really seem very relevant or useful, you know, and we didn't learn much at all about people with disabilities. We didn't learn anything about how to interact with them the best and how to treat them medically the best and how to accommodate the office schedule for them. So all of those little things could be very easily implemented into the curriculum. And then they could also be implemented into continuing ed credits that are, you know, required for all healthcare providers.
Thank you. That's very astute. We agree with you. Any other questions for Mary or comments or reactions before we move back to Susan? Susan.
Mary, thanks so much for sharing your story this morning. I was thinking, you know, what you said about every person with autism being unique, and
Yes.
it's really important for the healthcare providers to listen to the individual or to their parents. I'm just interested in what kind of feedback you get from providers when you say that my child really has a hard time waiting, or please remove the spinny chair. Take my word on it. You'll be glad if you take the spinny chair out of the room. How does that go? Yeah.
Yeah, it's typically not well received because the disorder isn't understood, really. And I don't think they grasp the concept that this child is incapable of this task, right? They think that it's a parental problem, right? That it's a parenting problem, that it's a decision of some sort. But what the parent is trying to convey to the provider is, I'm struggling with this behavior. Can you please help me, right? And the provider just typically, from my experience, just shuts that down and doesn't take it seriously at all, because they're, and I've been in these shoes a lot every day, they're overwhelmed themselves, right? They have like 7 other people to see in the next hour. They don't have the time or composure necessarily to completely take in what that parent is saying. And then maybe there almost needs to be, like in an office, if there's a social worker, right? There almost needs to be a social worker or something that can sit down with people with disabilities and say, how can we accommodate you best, right? And document everything, put it in the chart, so that way their next visit goes smoothly.
Yeah, I love that suggestion of making a note in the chart. And it's not just for your peace of mind, for the parent's peace of mind, or so the kid has a more comfortable visit. It really, I think it makes it difficult to give health information and even do the basics of an exam when the parent's preoccupied with the child's behavior or discomfort and the child has had it. I
Yep.
really appreciate the suggestion.
Of course, you're very welcome. Thanks for having me.
Any other questions before we move back to Susan?
And Mary, I understand that you have to get to work, and so if anybody has questions for Mary, now is the last time that you can take advantage of that.
Yes, thanks for pointing that out. All right, with that, I will hand it back to Susan. Take it away, Susan. And thanks again, Mary.
Thank you very much, Mary.
Bye, guys. Thank you so much.
Okay, I'm sharing my screen. Wonderful. Thank you very much for having me this morning. I'm thrilled to be part of this series. Really grateful for Casey for reaching out to me and for offering this training. I am so appreciative of Mary telling her story, and that's exactly the kind of information that we're trying to get out, trying to sensitize healthcare providers to the needs of patients with disabilities and some basic skills that we think will help them provide better care to patients with disabilities. Today, I'll talk just for a few minutes about conceptual models of disability, because we think that it's important to have a framework of disability and recognize that some of the ways that many of us think about disability actually interferes with our ability to provide quality health care. Before I get into this, I really want to express my appreciation to the Pennsylvania Developmental Disabilities Council for their support of this training effort, and also to the Centers for Disease Control and Prevention that supports my time in this training. Okay, so today we will work on a conceptual framework on disability, appreciating that disability exists in the context of human diversity, lifespan perspective, wellness, injury, as well as social and cultural environment. We had a poll. I just remembered the poll. Hey, Tracy, can you pull up the poll? And when people joined, we asked about what you know about disability. Huh? 100% who could benefit. Thank you so much. So we agree. We really are hoping to reach a diverse audience of physicians, nurses, healthcare administrators, and the second part doesn't look like people got the second question: how much do you already know about providing healthcare to people with disabilities? Oh, one person is 100% confident. That's wonderful. I'm really happy that you're here. I hope that you learned something and you find this time beneficial. Thanks. To begin, I'll review a little bit of information for those of you that were here last month. Thanks for coming back. I'll review just a few things because I think it's important foundational information for folks that are joining us for the first time. And the first thing that many people find surprising is that disability is not not rare. According to recent data, 26% of adults in the United States report having some kind of disability. Now, this is not just autism, there's all kinds of mobility limitations, vision and hearing disabilities, mental health disabilities, developmental disabilities inclusive. So when you add up all different types of disabilities, it's more than a quarter of the U.S. population. And that means for healthcare providers, that every day you're likely seeing patients that have some type of disability. so that I think I'm preaching to the choir because they're all already here, but I think this data really emphasizes the importance of disability training for all healthcare providers. Because even if you don't specialize in disability, you will have patients with disabilities. Let's see if I can get to the next slide. There, yeah. The other thing we know about health and people with disabilities is that patients with disabilities face a lot of barriers. In fact, people with disabilities report being twice as likely having trouble finding a healthcare provider who has the skills needed to meet their needs, 3 times more likely to be denied care from the healthcare provider on the basis of their disability, and are 4 times more likely compared to patients without disability to report being treated badly, disrespected by a healthcare provider. And so for these reasons, we believe that healthcare providers just need to understand more about disability, understand that patients with disabilities face unique barriers and inequities, and that healthcare providers need to adapt their behavior and do some things a little bit differently to provide quality healthcare. And we had a poll. I can't see my notes. We had a poll here. Let's see if we can pull that one up. I'm wondering if healthcare providers are surprised by these barriers. So I'll give you guys a couple of minutes to weigh in and see if this is new. It's not new to one of you. And I would really love to talk with you guys after about your experience. I'm not surprising anyone with these findings, it looks like. Yeah, okay. All right. 3 out of 3, not surprised at all. Okay, I don't know if that's good or bad. It's probably not good. I'm going to end the poll then and move on. Thanks, Tracy. Okay, so what we did, the Alliance for Disability in Healthcare Education is a not-for-profit group. We started off as just a small, maybe a half dozen healthcare providers and health educators who are really concerned about the quality of care for people with disabilities, and work to provide disability training. You know, we had some nurses who had contacts in the School of Nursing, their local university, and they started providing some training on disability for nurses. And this is happening in a few places throughout the country. And we all got together and formed a not-for-profit group and are working to increase training opportunities for students in the healthcare profession, and realized that we were all teaching slightly different things, and came together trying to find out what is it that healthcare providers really need to understand. You know, it may not be possible for them to learn about every health condition that results in disability, or every specific genetic cause of disability, but what is the basic information about disability or skills that are really necessary to provide quality health care. And so the Alliance came up with a list of skills or competencies, and then my group at the Ohio Disability and Health Program wanted to get feedback on that list and get a broader consensus and input from more people with disabilities, family members, disability advocates, other health educators across the country, healthcare professionals, and disability professionals. And so we recruited a large group of disability stakeholders, and we shared the competencies that the Alliance came up with, and asked them for feedback. We asked, what are we missing? what should we change in this list? Are these clear? Are they really relevant to your life? And we got a bunch of feedback. We modified the competencies and sent them back out to the same group until this large group of stakeholders all agreed that the competencies reflected the skills, knowledge, attitudes, experiences that were essential for healthcare providers to meet the needs of patients with disabilities. And at that point, we said we have a broad consensus, and we came up with 6 core competencies that all healthcare providers, regardless of whether they're nurses, physicians, physician assistants, occupational therapists, psychologists, social work, everybody, these are core understanding that all healthcare providers need. And importantly, they are as relevant to caring for patients with autism as caring for patients who are blind or deaf or have a mobility disability. They're kind of a baseline knowledge. And we're going to, these trainings are organized by competency. Today we're talking about contextual and conceptual frameworks on disability. Next month we'll talk about professionalism and patient-centered care, legal obligations, and caring for patients with disabilities as a healthcare provider, teams and systems-based practice, clinical assessment, and clinical care over the lifespan. Last month, if you were here, we talked about guiding principles and values. And what we found as we were going through the Delphi process and working with disability stakeholder groups, they came back and said that skills and knowledge are essential, but it's also really important that you have kind of a shared values and principles in approaching patients with disabilities. And so in addition to the 6 competencies, we developed a set of guiding principles and values. And we talked about that last month. I'm not going to spend time on it, but we'll mention again that all of the core competencies and the guiding principles and values are available online free of charge. And we'll share a link to the core competencies document for you. Okay, today we're talking about contextual and conceptual frameworks on disability. So what are we talking about there? And we recognize that disability has to be considered in multiple contexts. It's not just about the medical or biological cause, etiology of disability. It's not just about the direct physical impairments or implications of that disability. It's important to understand the context in which people live. And so part of that is recognizing your own framework, where you're coming from and how you think about disability, and recognizing that there are other approaches. And so the first competency or subcompetency in this area is defining disability as a functional limitation and recognizing the prevalence of disability that we talked a little bit about before. So we want healthcare providers to be able to talk about the diversity, the range of different types of disability, including mobility, sensory, cognitive, and behavioral disabilities. Secondly, being able to describe conceptual and contextual frameworks of disability. And I'll talk a little bit about what I mean by that. Many of you may be familiar with the biomedical model of disability. It's one of the most prevalent models of disability, excuse me, particularly in healthcare. And this model, our understanding is that disability is a pathology. It's a dysfunction within an individual person, and it's the disability that causes or that is individual's physical or mental limitations, and that healthcare professionals are needed to correct or modify the condition. And so the goal in a biomedical model of disability is for health professionals to diagnose and cure or at least ameliorate the defects to improve function. Another model, I don't have a slide for, another model of disability that's really prevalent across society is the charity model of disability, where disability is seen as a tragedy, and one should contribute to helping people with disabilities. So, and these models are not mutually exclusive. Very often people feel sorry for people with disabilities, imagining that their life is really limited and unhappy. And we imagine ourselves as, if I were ever to have a disability like that, I would be so miserable. I wouldn't even want to be alive. And we hear comments like that often. And these feelings are even manipulated to convince us to contribute to different social causes. The only limitation in a problem with the charity model is that for people with disabilities who are independent and want to be independent and really don't want to feel pitied, they want to feel respected, it can cause serious barriers to them in their independent living. So just to raise that, help you be more aware, and oftentimes we don't even think about the model that we're approaching disability from. So if you can recognize some of the biomedical model in your understanding of disability, let me go to the next model, which is the social model of disability. And this is actually was developed by people with disabilities. They were thinking about how they view their own disability and recognized that it was really in stark contrast to the biomedical model, and certainly in opposition to the charity model of disability. And as they were pulling their thoughts together, they viewed disability as a societal problem. It's not an individual pathology, they say. They say that the disability is a functional limitation, and it's caused by inaccessible, inflexible social and physical environment. And the solution is not to fix the disability. It's not physical therapy or even adaptive equipment like wheelchairs. It's really for the social and political system to remove systematic barriers. It's to address the derogatory attitudes and social exclusion that interfere with giving people with disabilities equal opportunities and allowing them to participate in society. And so, just a quick example, if a person, suppose the problem is that you've got a patient who isn't able to climb stairs and needs to climb stairs to get to work. And so the biomedical model would dive right in, and we would try to get the person physical therapy. Maybe we would look and see if there's any surgeries that can help the person to climb stairs, or physical therapy to climb stairs, and anything that we can do to reduce that limitation, to improve the condition for the person, to make them less impaired. Or if they've exhausted all of those options, then looking to engineering, or wheelchairs, or maybe even wheelchairs that go up and down steps. They have those. Anything to allow the person to access the steps. That's the medical model. The social model of disability isn't focused on the person at all. They're focused on the steps. Why do we have steps in the first place? Why can't we build ramps that would make it accessible to people regardless of their ability to climb or not? If one had a ramp, then people who walked and were able to climb steps would be able to access the facility, as would people who relied on a wheelchair to get around. And so it's a very different perspective and focus of the intervention. So that's the social model. There's one other model I'll talk about. The World Health Organization, about 10 years ago, was struggling with how to think about disability from a health framework. So you may know that the World Health Organization developed the International Classification of Diseases. It's a huge text kind of chronicling every kind of a disease and condition. And it's important, for billing and for communicating among healthcare professionals to have these conditions cataloged. And what they were struggling with was how to fit disability into this catalog. They recognize, disabilities have a cause, and you can have spinal cord injury, for example, in the International Classification of Diseases. But the problem was that you can have 2 or 4 people with spinal cord injury, but they function very differently. Maybe one person with a spinal cord injury has no feeling or ability to move their lower extremities at all, and the other person is able to walk with a walker or with crutches. Even though they have the same injury, even at the same level of injury, but they function very differently, and those are significant differences. Those differences matter in healthcare. And so anyway, they came up with what's called the International Classification of Function, Health, and Disability, or ICF for short. And what they did was they combined the biomedical and the social model of disability to try to understand not just the causes of disability or the limitations in functioning, but also how those causes interact with the person's limitations in activity and participation in society. And so real appreciation for contextual factors that influence a person's life. Okay. So when thinking about patients with disabilities, it's helpful to try to shift your framework and think about the disability, disabling conditions from biomedical, but also from social and ICF functioning perspectives. So the third subcompetency here is being able to compare and contrast the biomedical, social, and ICF models and think about how those models apply to healthcare for patients with disabilities. Another really important fact in caring for patients with disabilities is kind of understanding a little bit of the history of the disability rights movement and recognizing that people with disabilities have been fighting for their civil rights and their right to live independently and to have agency over their own lives for forever. And in the United States, there's a very rich history through the 1960s and 70s of people with disabilities advocating for themselves and demanding rights and accommodation. And these actions, these advocacy efforts have accumulated in several pieces of legislation we'll talk about in a few months. But I think it's important, especially for healthcare providers, to appreciate the independent living movement and the history of people with disabilities and their efforts to be treated with respect and to be able to live as independently as they can. Because I think that, of course, you need to think of people with disabilities with respect, and it really challenges the charity model of disability that many of us unconsciously carry with us. Another important part of the conceptual model of disability is appreciating how social determinants of health directly impact people with disabilities, and recognizing that people with disabilities as a social group are more likely to experience discrimination, barriers to employment, education, transportation, housing, poverty, and access to healthcare. So all of the social determinants of health that affect the health of people from marginalized identities, racial and ethnic groups are also adversely impact the health of people with disabilities, who incidentally may also be from other marginalized social groups. And that's the other competency that I think is really important here, is being able to think about disability as one identity and recognizing that people with disabilities have many other identities. They are mothers and fathers and employees and churchgoers, and then maybe they have a racial and ethnic and sexual orientation and gender identity that coexist with their disabilities. And it's important to appreciate that cultural context and to be culturally sensitive to their many identities, as opposed to viewing disability just as a negative health outcome, which is how we were taught to think about disability. And finally, we believe that disability training is essential, and that it really can improve healthcare for people with disabilities. We believe that giving future physicians, nurses, occupational therapists a chance to interact with people with disabilities, to learn about their lived experience, to challenge their own biases, that they will be better healthcare providers. And that's all I have. Thank you very much. So finally, we have a final poll question. Do you feel prepared to talk about the different models of disability in providing healthcare to patients with disabilities?
Thank you, Susan. I'm Cliff with the Perry County Health Coalition. I've been asked to facilitate any group discussion here for the last, we've got about 10 minutes, and it can either be a question for Susan, it can be a comment that you'd like to make, or it can be an experience that you've had, whether that may be good or bad in working with people with disabilities. So I'm going to open it up. Raise your hand if you wish to ask a question or share a comment.
And we have a small enough group. I'd be really interested to hear from our guests about what, how they heard about this training and what their experience is in providing healthcare for people with disabilities. Have you had training before? Have you had good experiences, bad experiences? I was listening to Mary and I was thinking, the things that she was saying apply to so many people. I mean, certainly a lot of people with disabilities, but some of her ideas seem to me reflective of patient-centered care. You know, trying to adapt the care of the patient to the patient's needs and to their priorities.
Hi, Susan. It's Max Hurwitz. I'm a provider in Pittsburgh. Your one thing that's come up, you know, it seems like in this discussion is creating a space to provide care for people. Like when they come into some type of healthcare environment, and we've been talking about that a lot at University of Pittsburgh. But it's all very much, it seems at this point, to be surrounding creating a physical space so that we don't have physical barriers. You know, our countertops aren't too high, or the doors can open and close easily, or somebody can get on an exam table. But I don't think we've had any discussions on, you know, how is the lighting affecting somebody, or how is the wait time affecting somebody, or how is the way we're communicating with folks or screening folks affecting them when they're coming in and impacting their comfort and care. So it's very helpful today to hear about that.
It's so wonderful that University of Pittsburgh is prioritizing physical access, and there are so many barriers for people with mobility limitation. It's awesome that you're aware of that and that there's the will to make those changes. The interesting thing is a lot of times those changes are the ones that cost money. And there's many things that can make a healthcare setting more accessible to people with disabilities that doesn't cost any money. You know, improving communication, getting information about needed accommodations ahead of time when a patient first schedules their appointment, so that the healthcare team can prepare. I love that that they're recognizing that need, and that there's a political will to make some changes.
Well, it's a process that's in place, so we're working on it for sure. But thank you.
Wonderful.
Any other comments or questions, or an experience you'd like to share? If not, I will turn it back to Casey for any closing comments. We have like 4 minutes. Casey, I guess it's back to you.
All right, thank you, Cliff. I guess it really just falls upon me to thank everybody. Thank you, Susan. Thank you, Mary. Thank you, Cliff. Thanks, Tracy and Lauren from Ohio State University for organizing things on the back end. And thanks again to everybody who came and participated today. And please join us for the next one in February. We'll be sending details about that shortly. And have a great rest of your day.
Thank you.
Thanks, everybody.
Bye-bye.
Thank you.
Sure.
Bye.